maybe a quick lecture.
Yeah.
Oh, good. I'm glad you're recording it. A quick lecture, maybe how I got started in addiction as a family medicine, what had happened, and just some how it's associated with all the integrative things we talk about in other fields. And then I just wanted to end it by letting people know that the practice pathways, which means without doing a fellowship, is still available to be board certified by the Osteopathic Addiction Board if you do a little addiction in the next few years. So basically, as you know, I'm the DIO, or the Director of Graduate Medical Education, of 40 some programs in two Miami hospitals, and the ACGME has now made addiction finally a core requirement for internal medicine, and they've asked me to talk to all the groups. So we have a pain group and PMR group, et cetera. So anyway, pain and addiction is something that a lot of us face. People are in pain, people have substance use disorder. What do you do? Nevertheless, how I got started in all this is back in the day when obesity was in, right? Remember, all of a sudden the government said, we're too heavy, childhood obesity, and you could change those words from obesity to addiction. Back in the day, 97 million adults in the United States were overweight or obese. At that time, I felt that primary care should really be in the heart of this, weight management and primary care. Or today we could say, addiction in primary care is really where I feel is the problem in this country. Is not enough people, not enough primary care are getting into helping our patients with substance use disease. However, I realized back in the day when I was a general practitioner that, I was getting patients that said, I need help from other physicians that said other physicians told them just don't eat or exercise, and it wasn't working. And I felt this was a not shut your face type of thing, that it was more of a people need help, just like they need help, in other things. They need more than just, they need an integrative program, maybe some medication, maybe some therapy, and lifestyle changes. And that's how I kind of got involved. When substance abuse came along, I realized it was similar. It was a disease like anything else. So fast forward, here we are to 2010. And look at this, in 20 years, the kilograms of opioids sold and deaths due to opioids just kept climbing. So, and I see a few people joined. If anybody has a question, let me know. If anybody has a question about how I do it, what do I do if someone has pain or addiction, or just pipe in and feel free to ask. So there goes my career. I'm up to 2010, and the next slide doesn't want to load. There we go. And now we're up to 2015. There were, reports anywhere from 60 to 80,000 people died from overdoses, and it keeps climbing. And there we go into 2016, and some more. We talk about any type of opioids, but heroin really, until about recently led the pack. As you know, most of us haven't seen heroin in over 2 years. When I get a call from someone, oh, we got heroin, I said, no, send it for a confirmation. Indeed, it comes back as fentanyl. And that's one of the biggest problems is fentanyl can kill you, and a lot more than heroin, stronger, longer acting, and, a smaller amount. And our dealers don't actually have these great scales. They don't care exactly how much is in there, et cetera. And so I think we all know some of this, and we all know that. So just a couple of words maybe about pharmacology and things that I like. Opioid agonist drug effects. We'll just move past this. Usually, my patients are on the bottom. They're physically dependent. They have high tolerance because of chronic use. And when they start nodding out, then that's a problem. The next slide talks about agonists and antagonists. So here we go. On the top, we have full agonists, right? Whether it's heroin, whether it's Oxycontin, or methadone, morphine, etc. Those are full agonists. We're used to them. They hit the mu receptor very hard, and they take away pain. On the bottom, you will see antagonists. right? So on the top, back to the top, a full agonist would be like methadone. And methadone is one of the treatments, as you all know, for substance use disorder or opioid use disorder. On the bottom is something like naloxone. We're all familiar with Narcan, right? So, if you take a naloxone, which is available in a daily pill, or what I use more frequently called Vivitrol, it's a month-long naloxone. It's 380 milligrams, and it's a pure antagonist, right? So when my patients start using their fentanyl or opioids, after a while, they say, Doc, I didn't get high, what's going on? Or they realize they're wasting their money, and you kind of try to explain to them, well, we put you on an antagonist. So they stop using. Now, in the middle is my favorite medication because it has a high retention. I basically have a love affair with buprenorphine. It's the #1 drug in my mind underutilized in this country. It's a partial agonist. And what it doesn't show on this slide, it's a partial agonist and an antagonist. So I tell my patients it's a smart drug. In other words, it'll stop withdrawals because it has some opioid. It's also used for pain. There's a Butrans patch. There's a medication called Ubelca. And so it's a smart drug, right? Because it stops withdrawals, but it really loves that mu receptor and will not let anything else in. So I kind of like that drug for many reasons, including, the fact you can't overdose it. So let's take another quick look. The full opioid antagonist, which we discussed, is the mu receptor. It occupies without activating. It's not reinforcing or rewarding. Oh, antagonist, I mean a blocker, I'm sorry, like naltrexone. It blocks or displaces the opioid agonist. So you want to be careful. You don't want to give somebody a month-long shot if they have opioids in their system. So, of course, a drug screen is used. And sometimes you may want to use a test dose. I say, I'll tell you what, we'll give you the naltrexone 50 milligram pill, see how you do. And if everything's good, we can give you the whole month. This includes naloxone and naltrexone. Now, the reason I like the partial opioid agonist a little more is because people seem to like taking a pill. And it seems to be more compliance. I have less drop off. It hits the mu receptor as again, where it's a partial agonist, not a full agonist. Again, it activates the mu receptor with sealing effect. So let me say that again. Activates the mu receptor with the sealing effect. What does that mean? If everybody looks up, what does that mean? Who knows what that means, a sealing effect? Well, it means you can't overdose on it. Another reason I love buprenorphine, there comes to a point, you can't overdose on it, is relatively less reinforcing and rewarding. Most people don't seem to catch a buzz off it. Most people don't seem to abuse it as much. It's a less risky opioid, right? Less sedation, less respiratory depression, and it basically includes buprenorphine. And it's available in different forms. You have the daily buprenorphine medication. We all have heard of Suboxone. I don't use Suboxone because about 80% where I come from in Detroit and probably nationwide is diverted and sold on the street. I like to use the competition to it. Nobody's heard of Subzolve as much. When I first started working and in the Detroit area, I'd have people coming all the way from Flint demanding buprenorphine. And I said, well, let's try something else, and they didn't want to. I told them they can go elsewhere. Or if I checked their urine, I would see no metabolite in there. It was obviously they were diverted. And then, like we talked about, the nice thing about buprenorphine, and I won't mention a whole lot more, we said it hits the mu receptor. So it is high affinity. It has extremely high affinity for that receptor. Again, it will displace the agonist. It will push out the agonist or the opioid, right? So you want to make sure that the patient is starting to go into withdrawals. And that's kind of easy. You know, we all know the Cal scales. My patients come in, it's obvious they are in withdrawals. If they're not in withdrawals, they know whether they may have used, you know, right before they came in. They kind of know how not to put themselves in withdrawals, wait till they're feeling bad. And as I tell them, you know, within 30 to 60 minutes, you'll feel good. You'll stop your withdrawals. You'll feel much better. And so the important part here is it has a very, very high affinity for that mu receptor. Now, it sticks around a long time, right? Receptor dissociation. Dissociation is the speed of disengagement or uncoupling of a drug from the receptor. Buprenorphine's dissociation is very slow. It stays on that receptor for quite some time. So therefore, it will block opioids for quite some time, or like methadone, which others cannot. So I don't know, there's some people in the chat. Does anybody have any questions, Bill? Can you all hear me?
Yeah, we're good. Yeah, we're good.
Okay, so if you see any-
DO means doctor of offending. That's a joke.
All right, if anybody has a question, Bill, stop me, all right?
I will, not yet.
All right, you got it, or we may
Keep going.
save it towards the end. Now, you know, there's a couple things about treatment. You know, if you go to PCSS, Provider Clinical Support Services, you can pick a mentor. The mentor is free. They'll call you. You could pick me. You have any issues, somebody comes in your office in pain, but you think they're abusing substances, you know, what do? You call me and we help. If you can't, you know, do the best you can and document your reducing harm. And here's the real key. If you look at these medications that are used for substance use disorder, whether it's methadone, whether it's the naltrexone, the full agonist, or the full antagonist, or the one in the middle, the agonist antagonist, the indications for the drug clearly states it's indicated for substance use disease with therapy. So we must integrate care. So whether it's primary care plus behavioral health care and the medication, whether you're maybe seeing a rheumatologist because you have lupus or you have, you know, rheumatologic severe osteoarthritis, we have to integrate care. And when we work together as a team, that is the buzzword right now. And the ACGME, when I talk to my residents and fellows in the 5 addiction clinics we started in FQHCs, our goal is to integrate care. And during COVID, we were lucky. We were great. We had a 68%, probably one of the highest in the nations, and one of the FQHCs in Detroit, 68% of our patients were getting therapy. You know, we had therapy there. And, you know, so therefore it was easier. Plus, my bosses would, you know, be on me. And if the patient would miss their therapy, then, you know, I wasn't able to give them a whole month of medication. Maybe I'd back it off to 3 weeks, 2 weeks. And because studies have shown if you integrate care, and that's really the key word, to kind of work together with all the other providers. And then as we kind of said, we talked to some of the PMR residents, we talked to some of the pain fellows, internal medicine residents, and, you know, pain medicine specialize in the management of patients suffering from acute and chronic pain, or pain in patients requiring palliative care. What is pain exactly? The International Association for the Study of Pain defines pain as an unpleasant sensory and emotional experience associated with and resembling that associated with actual or potential tissue damage. In medical diagnosis, pain is regarded as a symptom of the underlying condition. The management of pain is a complex matter involving multiple disciplines. Again, an integration of care, multiple disciplines, you know, the family doctor, the internist, the rheumatologist, the neurologist, whichever modality they're seeing, and of course, the behavioral health component to all work with the patients. All pain specialists, regardless of the specialist, should be knowledgeable in pain assessment, formulation, and coordination of multiple modalities. That is the key, multiple modalities for the treatment, including integration of pain treatment with primary disease management. What is addiction? So let's just talk these, let me read off these slides, because addiction is defined as a chronic, relapsing brain disease. It is characterized by compulsive drug-seeking use despite harmful consequences. So it is considered a brain disease because drug changes in the brain and its structures are how it works. These brain changes can be long-lasting and can lead to very harmful behaviors seen in people who abuse drugs. Addiction is a lot like other diseases, whether it's diabetes or heart disease. The normal healthy functioning of the underlying organ has serious and harmful consequences and are preventable and treated. But if left untreated, they can lead to, a lifetime of demise and or premature death. And, here's I show some of my patients. So this is decreased brain metabolism in a patient who abuses drugs. Basically, right now, we've seen those color flow Dopplers of the weather. If you did a color flow Doppler of my brain right now, what do you probably see? Green, orange, blue, because I'm having a good time here. I've got, 18 people on the line that are listening to me. You should talk to my ex-wife. No, just kidding. And I feel good. My patients are not metabolizing glucose. Our patients' mu receptors have been destroyed. They don't have any color. So, I tell my patients, look, it's going to take some time. Once you stop these opioids, your brain's going to be like those mu receptors and the GABA receptors and they're going to be like, whoa, you're not bombarding. I'm not being bombarded. What's going on here? And then as time goes by, my patients, the ones that succeed, start saying, I feel normal. And I tell them it takes time. It's going to take a process for these mu receptors to kind of clear to where dopamine is going to do something. I tell them when people have sex, watch a good movie, eat food, they release dopamine. You don't have any. This is going to take a little time. So let's clear those mu receptors and let's have small goals. So why do people use substances? As we know, in general, people begin taking drugs for a variety of reasons, some to feel good, some to feel better. Some people who suffer from social anxiety, stress-related disorders and such begin abusing drugs to just help their stress. Stress plays a major role in beginning drug use and continuing drug use and in patients recovering. Some just do it because they're curious. Most, I get people ask me, well, why do some people, use drugs and others don't? Well, some people don't like opioids. That's the start. So if you don't like them, there's a good chance that when you're using it, you won't continue it. But most of my patients, some of them, in high school, they started partying a little bit and that was an issue. But I say a large majority, have had some episode. Most of them have some post-traumatic stress event as a child, and they self-treat. And of course, there are those who were an offender bender or who went to a dentist and just unfortunately, came back a month and came back the next month to their PCP and the next month and said, hey, I need a little more. They liked it, and then they got dependent on it, where they could not be without it. My patients really are not using substances or fentanyl or opioids to get high anymore. I think we all know why they're using it. It's to stave off withdrawals. The idea with some of your practices, whether it's primary care, whether it's rheumatology, neurology, is to keep people, if they're dependent, keep them from getting addicted, keep them from doctor shopping, and talk to them about their dependency. So, we have some people, like we said on the left, who are just severely depressed and And why exactly? Well, I may win the Nobel Peace Prize if I knew exactly why some people just do get depressed for no reason, and why other people on the right are enjoying themselves and clubbing and things like this. I think my resident put this slide in there. And we talked about it. Why do some people become addicted and others don't? Basically, some people can delay gratification and some don't. But in all actuality, whether it's partly environmental and partly genetic, I tell people, if I really knew, I'd probably win why the circuitry in your brain is a bit corrupt. I probably would win the Nobel Peace Prize. So, risk and protective factors for drug abuse and addiction, of course, risk factors, aggressive behavior in childhood, lack of parental supervision, poor social skills, drug experimentation, availability. It's when you talk about availability of drugs at school, you can look at the word availability. Alcohol is available. So, during COVID, where I was at the time in Michigan, the only stores that were open were the alcohol stores and the medical marijuana stores. So when something is available, it's just easy to use. So in this country, unfortunately, we have a market. Drugs are sought after. People can make money off them. People buy and sell. And I thought we were getting somewhere when the opioid deaths were decreasing from 100,000 to like 80 to 60. But when COVID hit, we went back up last year to over 100,000 opioid deaths. So if we have protective factors, good self-control, I guess some of that's taught and some of that's genetic. If we have parents that are monitoring and support, positive relationship, academic competence, school anti-drug policies, good communities, etc. These are some certain protective factors. And yes, most of our patients are in the lower income level. We serve pretty much the Medicaid and the poor population and the safety net of people that end up in our hospital emergency rooms. So we talked about biological, environmental, and then again, another branch of medicine to integrate another group of residents that the ACGME wants us to talk to. They want our neurology residents to graduate, right, with an idea of how to prevent substance use, because most patients see neurologists for what? Headaches, things like that, pain. Neurology is a branch of medicine dealing with disorders of the nervous system. Neurology deals with the diagnosis and treatment of all categories, conditions, and diseases involving central and peripheral nervous system. This includes their coverings, blood vessels, tissues, and muscles, etc. Medical knowledge. So just to give you an idea of what the government, your tax dollars, that are paying for each resident, $150,000 per year, to train these residents, and what the government wants us to finally, teach them, and a set of rules, because this is new. They're going out into the world, and maybe we should all. I learn every day. I learn every day as I see what they have to learn. Residents must demonstrate competence in their knowledge and diagnosis, pathogenesis, treatment, prevention, and rehabilitation of those neuromuscular, neurobehavioral, and other system disorders common to this specialty in patients in each gender and ages. Residents must demonstrate knowledgeable of the principles in pharmacology as they relate to the indications for the complications of drugs utilized in physical medicine and rehab. Now, this is a bullet point, which most recently I was given, by the ACGME, American College of Graduate Education, with a list of about 10 different type of residencies that they wanted now them to graduate with instead of learning after they graduate. So it really should affect all of us. These are simple principles, but let's read them. Prevent substance use disorder while ever possibly when you're treating pain. You must treat the pain, but be careful, watch your patients, have them come back frequently, look for warning signs, look if they come, they tell you they're needing more, if they tell you they're running out of their prescriptions early, something isn't right. 2, recognize substance use disorder in its earliest stage. And, when they come back to you, I think you'll be able to recognize it. Some states would like you to get a $3 or $4 cup, right? And those cups for under $4 have everything on there, not just cocaine and marijuana. Some test for marijuana, some don't, but and amphetamines, opioids, methadone. They are also, for under $4, have alcohol, fentanyl, and buprenorphine on these cups. So you could actually make sure, most important, they're taking their medicine. Some of my patients, I'm looking at this, wait a minute, didn't I prescribe an opioid like 2 weeks ago? Where is it? It's not in your system. You could send it for a confirmation, 3, function effectively in systems of care for effective pain relief and substance use disorder. People are in pain. You want to help their pain, but you want them to function. So there's a big difference. If you have somebody who, say, is taking, 4 narcos a day, but they're going to work, right? They're supporting the family. They're coming home at night. They're sitting with their family and having dinner. That's a big difference than someone who just is coming to you every month, getting 3, 4 narcos, sitting home smoking pot all day. It's a big difference. So I have asked our residents, forget about so much the pain score, because it's really just very, subjective. The most important vital, most of my patients are young and healthy. So after the blood pressure, the pulse and respirations, write down function. How is this patient functioning? If this patient is functioning well, note that in the chart. Patient's functioning well, doing well, refill prescription, refill present course of therapy. Patient's not functioning well. They're sitting home all day. They're going to the ER a bit much. They're calling off work. We need to make a change here. It's like, why are nursing home patients who stay in bed all day, on opioids or amphetamines or opioids and benzodiazepines? They're not functioning well. 4, use non-pharmacological means whenever possible. We're all taught to use, pharmacological means, or, use non-opioids whenever possible. So I go around the room. Bill, I remember back in the day, there were so many different anti-inflammatories, whether it was, Relafin, or Daypro, Naproxen, Advil, there were so many, but people just seem to forget this. And then I say, well, what forms do they come in? Well, they come in creams, they come in liquid, they come in oral, there's Tylenol, there's acupuncture, there's hypnosis, there's osteopathic manipulation. Really. And the more and more you look at it, there's patches, people just don't realize that there's a lot out there. Any modality can help you, that won't get you dependent on something. And 5, the government would like, our residents to participate in clinical trials of non-opioid pain relief and publish journals. And these trials should help the clinical disorders of the populations they serve. So this is the type of thing that our young doctors in all fields should hopefully finish, get their degrees in. And another residency we have here down at Larkin Hospital in Miami is PMR, right? Very important to try to get somebody functioning again. Very important branch of medicine. Physical medicine and rehabilitation is also known as physiatry, a medical specialty that involves restoring function. There you go, function. Let's restore function for a person that has been disabled as a result of disease, disorder, or injury. Physiatry provides integrated, there we go again, keywords, function, integration. Integrated multidisciplinary care aimed at the whole person by addressing individual physical, emotional, medical, vocational, social, and spiritual needs. Let me add that up in there. Address their spiritual needs. It's a doctor who specializes in physical medicine rehab. They're called physiatrists. So again, another branch of medicine that is involved in this integrative care concept. There are system-based competencies, epidemiology of pain, overdose and rescue therapy, interventional pain therapies, opioid conversion. And of course, we have an osteopathic program, probably one of the best in the nation. Dr. Joel Stein leads that, and I was just in his office today at Fort Lauderdale to see these young residents doing manipulation and putting their hands on people. It just kind of makes you feel good, you know, and to see them with their new ultrasounds, they're running around. We never had these. They look like children running around with ultrasounds so they can find exactly, you know, we used to take a needle, we used to put it anteriorly or posteriorly in the shoulder, but now, you know, they're doing it under ultrasound. They're injecting tendons, even carefully under ultrasound, joints. Osteopathic manipulative therapy is hands-on treatment method. It is sometimes called osteopathic manipulative treatment or osteopathic manipulation. You know, we all know this, and it's just another modality that's excellent. There is no doubt in my mind that one of the best addictionologists is, you know, primary care, family doctor, or someone who's treating the patient as a whole, neurologist, rheumatologist, knows the patient. But the best physician is that who has another tool. We're all learned another tool, right? So we're all learning osteopathic techniques. So AT still is probably looking at us up in the sky and saying, I told you so. I told you so. We need to use less surgeries. We need to use less medications, and we need to think about the body and other modalities that can help himself. May he rest in peace. He was 100 years before his time. Oh, any questions so far? And I'll take a slight break. Any questions? All right, let's continue and see if we can wrap this up. But this is a true story. So this is really true. You may have heard it if you went to the lecture. But Alice, I got a call from Nicole, my office manager. Alice, as I recall, she's about 72. She hobbles in the office. She drives. She gets, back in the day, I think I was giving her lisinopril, metformin, a few narcos. And I guess she showed up in the office that day with her granddaughter. I really didn't recall. And I get a call from Nicole, my office manager, that she called. Alice called and said the dog ate her narco. Oh, I don't know. I didn't pay attention. Or I just, whatever. You know, well, what did I do? I said, refill it. But then the next day, or later that day, I said, something isn't right here. Something wasn't right about this office visit. Her granddaughter came in with her and went into the room and said, I'm now helping grandma. I'm going to help her with her meds and such. So I called up Alice and I said, I just wanted to talk to Alice, and said, Alice, why? I said, Alice, how are you feeling? I said, why didn't the dog eat your blood pressure and cholesterol pills? Does anybody know what Alice told me? Anybody? Alice said the dog didn't have cholesterol and blood pressure problems. Ha ha ha. Next one. This is another slide that I probably go over 2 or 3 times with the residents, and I feel very important about it. We're graduating them. I have a few remarks to make at graduation. It's going to be this: never judge. Take all those that come before you. Reduce harm. If you don't know what to do, you're not sure, you get a psychotic patient who's complaining of pain and addiction, just document, in order to reduce harm, I did this. That's kind of like the key word. No one can hold your responsibility. That is the idea. Try to reduce harm. And why do we use medications? Because 80 to 89% relapse without the use of medication-assisted treatment. And we talked about the 3 medication-assisted treatments. I may have a graph later. Increased treatment retention when these people are taking medications and come to see you. They see you, they're in treatment. Anytime you can get somebody in front of you, even if I wish I was treating heroin addicts with heroin, if they can come before you once a month, then maybe they'll want to go to rehab finally. 80% decrease in drug use and crime, 70% decrease in all-cause death with people on medication. Medication-assisted treatment, that's the key word now, MAT, medication-assisted treatment. Again, that's either methadone or Vivitrol, the naloxone, or buprenorphine. buprenorphine, those three. All treatments work for some people. It's like anything else in medicine. No one treatment works best for one person. And the goals of medication assisted treatment, like we said, alleviate signs and symptoms. If they can walk into your office in withdrawals and you can give them medication to stop their withdrawals, then that's really what it's all about. That's what we went to med school for, right? To make somebody feel good. Like if someone walked into your office and you gave them a shot of Toradol. God, even when I get home at night, it's been a rough day. It's been a long day. Maybe we have a few minutes left, God willing, for our families, our spouses. But if one person, I tell my staff, my residents, one person did not go home and stick a needle in their arm, then you did something good. And I tell you, it may be a long day. Some of them may be difficult patients, but you'll sleep good at night. You will really sleep good. And again, methadone, full agonist, buprenorphine, partial agonist, naloxone, full antagonist. Different treatments. Dosing, methadone is tough. You got to go to, we have a methadone clinic. You have to go there every day. It's very highly structured. And buprenorphine, it's taken daily, but now we have buprenorphine in a monthly subcutaneous injection called Sublocade, which is great. I like to use it for people who use and divert. If they just divert, they can go sell it out of my clinic. But sometimes they're using, I say, look, I'll give you a monthly shot if you really want buprenorphine. People that want the monthly injection tend to do better. The long-acting naltrexone is every 4 weeks as well. Buprenorphine, and then our oncology group. Well, another drug. Why would I be consulted on a cancer patient? Has anybody ever been in rehab and been in remission for many, many years and gotten cancer? Well, it's happened, right? One time, a guy had metastatic liver disease, was in pain, and just did not want to take those opioids that were prescribed for him because he was afraid that he would go back, because he has some cravings, and go back to heroin use. Many patients with cancer experience moderate to severe pain, requires treatment with strong analgesics. Buprenorphine, fentanyl, and morphine are examples of some strong opioids that can give some pain relief. And buprenorphine may work, so for that situation. And we talk to the oncology people, and studies have shown that for some patients, buprenorphine actually does work well for cancer pain. It may be less constipation, and there may be some benefits. And as you know, back in the day, someone had lung cancer, as you recall, they weren't going very far. But nowadays, there's a lot of good cures out there, and maybe it would be great, if they weren't became opioid dependent or even went on to addiction. And another story, this is a true story. I had a patient, and I was giving him high dose buprenorphine. He had lung cancer. He was inoperable because his COPD was so bad. They were afraid to remove a lung. I didn't look at the chart very well. He was friendly. He came in. I gave him high dose, 3 buprenorphines a day. Finally, I paid attention, and I'm looking at his confirmations, and I'm going, wow, these are very low levels. I looked at him and I said, how much are you selling these for? And he didn't answer me. He didn't deny it, but he didn't answer me. He got one over me. I kind of learned about diversion and learned to be smart. The reason I put this up is because, up there in Detroit, they were a heavy state. And now where I am in Florida, one of the highest. Back about 14, 15 years ago, Florida prescribed about 14% of the entire world's opioids, as the United States was prescribing about 80 to 85% of the entire world's opioids. It was a big problem here in Florida, and it sort of got helped and cleaned up a bit, and maybe a bit too much, as unfortunately some really good doctors are afraid to do the right, to treat their patients because of some problems. So, that's unfortunate. And I see out where some of you guys are, Nevada is also up there, right? So let's help some of these people. that are in the states that we live in. This is, again, this slide was back in the 90s when I was lecturing and being sponsored for weight loss. It seems similar to me. Help people, put them in a program. It's all, you can't just tell them, don't eat, go exercise. That just doesn't work. Bond with the patients. Have them tell you exactly what their stories are. Never become angry at a patient. We've all been guilty of this. And I'll get calls from my staff that Susie was just an a-hole today. Look, when somebody's going through withdrawals or when someone's using, give them a chance, okay? They're not the nicest people. And I tell my patients, in order to get your natural goodness back, what you were born with, we need to have a few months away from opioids so that dopamine can come back. Make easier goals if necessary. When you have a diabetic, if they go from an 8 to a 7.5, that's great. We're not going to say you have to be at a 6 overnight. So it may be funny, but when Steve comes in and I see benzos and cocaine in his urine, but no fentanyl, I'll say, okay, good. You stopped injecting, you won't get HIV, you won't get Hep C. That's great. Okay, can we reduce? Can I see lower numbers? Can we now go on to the other thing? When someone's trying to lose weight, all I said to them was 1 pound a week. Studies show 4 pounds a month. And I put it this way, 50 pounds a year, smaller goals. I don't wean patients from 120 pills a month to 90. It just doesn't work. It doesn't work. But if you can go from 90 pills a month, 90 narcos a month, to say 80, hey, that's great. And then you may reach a plateau, but modest goals, easier goals, manage the patient's entire care. Some of the physicians that are listening to this really they know the patient. You send the patient to me, when I did family medicine and addiction, that was great. But sometimes you may have to manage the whole care, and they know you. Encourage support groups, encourage integration. Back then for weight loss, they were already talking about integration of care, support groups, other materials, different tools. So that's kind of where I got my start. And that's kind of, where I'm kind of ending. And again, never judge, take all those that come before you. And you will see reducing harm is what I teach them. And I will end my closing remarks when we graduate the new class on Sunday. Ask but one question as you go out into the world. Ask but one question of your patients. When are you coming? If I had one slide, that would be it for the young folks. Seymour Hoffman in The Hunger Games, a great actor. Didn't know there was fentanyl in the heroin he used. Some of us older folks, one of the greatest comedians, actors we've ever known, Robin Williams. Depression, suicide, etc. That would be my lecture. Maybe more of us would treat. Now, really shortly, I just want to mention, if anybody's interested, the Addiction Medicine Board requirements for MDs and DOs are quickly closing in terms of what's called practice pathways, where you don't need a fellowship. So if you're an MD, I think we're mostly DOs, and you practice a certain amount, practice option is this option within the practice pathway applies to all applicants who meet practice activity requirements as follows: 1,920 hours of substance use, either giving Vivitrol or antabuse or whatever you do. If you can document this in a 5-year period preceding the June 30th of the application year, you can actually sit for the addiction MD boards. And to be eligible for the DO boards, subspecialty certification, we reinstituted the addiction boards, the American Board of Osteopathic Addiction Medicine. To be eligible for addiction medicine subspecialty certification, or what's called a CAQ, without taking a fellowship is still open for a couple years. You must hold an active primary certification by the American Osteopathic Association, be boarded in neurology, family medicine, OB, osteopathy, it's emergency medicine initially, and then, or if you're a DO who is by the American Board of Medical Specialties, went to an MD residency, you need that. You must, if you don't complete an AOA or ACGME accredited fellowship, there's a way to do it. And that is to be eligible, let's see, as the fourth bullet, as part of the application, candidates are required to document and prove, where I am one of the guys that would sign off, an attestation form that a minimum of 1,000 hours of practice in the 24-month period were engaged in addiction medicine. Let's say 1 day a week. It is required that the minimum of 2 years practice be continuous. However, it could occur in a 5-year window. If you meet those requirements and an attestation form is filled out up until 2024 or 2025, so the window is kind of closing as time to meet those hours, you can actually sit for the American Osteopathic Board of Addiction Medicine. We've had 300 so far since we reinstituted the board a few years ago. And I can tell you the exam is not that difficult. And you just need a form signed. This is the form, the Addiction Medicine Clinical Practice Pathway. You say that you've completed this hour, you find somebody like me to sign it. And I just wanted to kind of let you know that if anybody is interested, they can reach out to me, 248-224-1999, or you can go on PCSS, Provider Clinical Support Services. You can pick a mentor who can help you as well. So if anybody has any questions, Bill, maybe you can shout them out. I see there's some people have been chatting. Anybody has a question for me, now's the time.
Excellent talk from a real world expert. Thanks for encouraging the integrative part. Any suggestions? Any suggestions with a good ramp up protocol that you like to use to start in starting pain meds?
To start pain meds?
Yeah, an example that he gives here is tramadol to hydrocodone to dilaudid, et cetera. So.
Yeah. Well, you know, the least amount of opioids that can control the pain. Tramadol back in the day was unknown mechanism of action, but today we know it's a partial opioid and it also is an SNRI. So even though I've had people on a blocker, they've gotten pain relief from that, probably from the serotonin. So, you know, I would consider buprenorphine also for pain. Okay, it's an underutilized drug that you left out of your step path, whether it's the Butrans patch, whether it comes in the form of Belbuca, you can go all the way up to 950 milligrams times 2. So I'm sorry to say this, but I'm not sorry to say this. I used to say in some of my lectures, opioids are not indicated for chronic non-cancer pain. Well, now I say opioids are usually not indicated because, of course, there are times, but I just don't like going up into opioids unless there's a cancer pain. So I go backwards. I start with SNRIs. As you know, Cymbalta is indicated for pain. So, you know, I'll use that. I'll look at their underlying conditions. Do you have insomnia that causes pain? You know, I just don't use opioids because I'm an addictionologist. I usually see people who come to me on too many opioids. Gabapentin seems to be a favorite of some people, you know, which, you know, is controlled in some states. So I'll maybe go up that ladder. I like to use Toradol. Oh, it sounds good, Toradol, you know, even though it was only indicated after an injection and only indicated for 5 days, that's because it wasn't studied. It was only studied to go head to head against Vicodin at the time, and it was shown effective. So I may use Toradol daily. It has no worse side effects than any other anti-inflammatory as far as the kidneys or heart goes. As I climb up, if somebody requires opioids that is not controlled on buprenorphine, then I have the luxury, and I want to keep them in our system. I'll be honest with you, or, I'll send them for epidurals, physical therapy, or I have a pain program in our fellowship. So I will say, look, it's time. Maybe you should, talk to the guys, who do that. Anything else, Mr. Bell?
Question on, is tramadol affected by naltrexone?
Is tramadol affected by naltrexone? Well, like I said before, I like to make physicians look good. So when I saw tramadol and an opioid blocker, I'm going, So if that answers your question, it has pain control by more than one mechanism. Serotonergic action. So if it controls their pain on this mild drug, it's okay with the naltrexone. It's okay.
Have you ever used naltrexone as an agent for detox? There is a low dose.
Some low doses shown to be effective. I don't really for detox. I basically, you talk for opioid detox. I myself use comfort meds, Catapress. That's where I use gabapentin. I don't really myself use, naltrexone in that situation. I pretty much just use naltrexone for alcohol cravings and opioid blocking.
The doses there are actually micro doses.
Yes, you're better at that than me, Bill.
2 to 4 microdoses. What about Cymbalta? Is there an increase in suicide, either ideation or attempt?
Well, again, if I've got a patient that is using substances, if I've got a patient that may be treating their underlying anxiety and depression, and I give them some Cymbalta, I'm reducing risk. And now when they do studies of antidepressants, naturally, there's going to be over placebo some bad events because these people are sick. So I don't buy into that too much. I have had a lot of success. What my residents do is what I taught them. They Google Cymbalta and they show it to the patient. It says right on there. And I go to the last sentence, fibromyalgia, neuropathic pain. And then I say to my patients, I'm not going to BS you because you were honest with me. It was first used for anxiety and depression. I kind of like that. If they say they don't like that one, then I'll go to another SSRI. So no, I'm not worried because I think that drug benefits far outweigh those risks. And that's the whole key with medicine and addiction, harm reduction.
How about there was something a little while ago called the Sinclair method, where they were using high dose naltrexone and sort of encouraging drug use. You had to use the drugs to sort of you just didn't get the high, or for alcohol. Have you ever?
As you know, naltrexone is indicated for alcohol use. That's why the Vivitrol, they don't actually the Vivitrol they're using it, the company's moving a little bit more towards the alcohol use because there's a lot of so I have seen some of that and it's very effective for alcohol use disorder. Most patients seem to drink a lot less or do well with that.
Okay. And I had a follow-up. Now I lost it. So, anybody else have any other questions or So are things getting better out there? I don't really deal with these kinds of folks. Or are they
Things
getting
just
better?
are
Are they
not
getting,
really getting better. I just don't get it. I do get it. I think because this country is the land of the opportunity, demand and supply. People want it. People will pay for it. You know, COVID just really put a damper on things. I mean, we have some patients, you know, that were stable. Did we want them in the office? Maybe they had COPD, so we passed up maybe a month. Maybe they caught on, you know, we weren't doing drug screens as frequently. Many patients couldn't get in to physicians. And we're just, so that messed a few things up. But, you know, moving here to Florida, because Michigan was a little more middle of the ground, and the poor and the homeless were being treated there. They had funds for it. Here, I'm seeing people getting discharged to the street. I don't want to get into that, but it's just, we need more providers I get it. Sometimes these patients are difficult. Sometimes these patients, you know, we're not paid enough. We're trying to get payment increased for some providers, but we need more providers out there helping. It's just, and I think that's part of the problem. But, you know, at least now, finally, for the first time ever in our history, residents have to graduate with addiction training. The ACGME, as of July 1st, requires all internal medicine residents nationwide and paying fellows to have some addiction training. So it's long overdue, long overdue.
Could I ask one question, please? Because another
Sure.
2 years, it was a great talk. One of the interests I have, and I send patients out of the country to be treated with ibogaine. So do you have any changes of opinion in the last 2 years on ibogaine?
You know, what I should be saying is when people ask me that question in particular, or other questions, any tool that I have in my bag is a help. If you can ease withdrawals, then that's a win. Ibogaine will ease their withdrawals or get them off. And that's the problem with my patients. They just can't go through the withdrawal period. I mean, they'll go out to that smoke store, Buffalo something, and you'll see these big vats of kratom they'll get hooked on, but it'll stop their withdrawals. If they can get ibogaine and it's a little more supervised, you know, then it helps them go through a withdrawal period, then great. You know, so yeah, any tool in the bag that can help, and anything that'll ease withdrawals may ease success. I mean,
Yeah.
Catapress or this new thing, Lucemyra, just, you know, the alpha agonists, yeah, they may help with your withdrawal symptoms a little bit, gabapentin, but you know, ibogaine, if you're kind of, your mind is out in another place, good, because maybe you can go through the withdrawals or stay, or, you know, keep off it. So John Hopkins finally, I think, or finally, the government is allowing studies of hallucinogenics. It took a long time. It's about time.
Yeah, and it's about 20 years behind, because I'm
Yeah.
familiar with Hopkins and their studies, and also with the psilocybin and psychedelic psychiatry. I'm interested in all of the things, but ibogaine can be very, very, very successful, and within 1 week, and you can be going from a heroin junkie to free in 1 week. So is there even any discussion going on? Because I know you're dealing with top level education, DEA, the X factor and all that, but is there even any discussion on ibogaine going on?
I haven't, you know, heard it on ibogaine, but at least I've heard openness to now hallucinogenics and research. So I am advocating any of our residents that in their research projects that they're required, I'd love to see it. There is Microdose here in Florida. It's an organization that is involved in ibogaine, and it's starting, John. It's starting. We don't have enough people to push it. It's all about the money. It's all about what people are going to buy. You know, it's about the prejudices. As we break those, and hopefully it'll come, to the forefront.
Yeah. Well, thanks for sharing with us.
Yeah,
Oh, you're
thanks.
welcome. You're welcome.
Thank you, David.
Welcome,
Anybody-
everybody.
Anybody
You
else
guys
have? Yeah. Go ahead.
Anybody else have a question or anything before we wrap it up? If anybody has any questions afterwards, you can get a hold of me. You can ask Bill. He's got my number. I shouted it out, 248-224-1999 is my cell. I'm available. I have resources. We have fellows. We'll be in Vegas again, next year, and hopefully we'll continue this, togetherness and integration. And, Bill, I'm hoping the AOA will start to show us a little more respect. It's coming.
I'm not so sure, but
All right.
so we got a
Well,
formal
you know
rejection.
what?
Yeah, we
Yeah,
got a
I get
formal
it, Bill.
rejection. Yeah.
You know what? I may be a dreamer, but I'm not the only one.
No, that's true.
All right. Thank you, everybody. Have a great night.
Thank you, Dave. Always
welcome.
great, Dave. Thanks a
You're
lot.
welcome anytime.
Thank you, everybody, for coming. We had a little kerfuffle last week and we were off. Next week, we have Dr. Scott Chandler, who's going to give us part 2. He's a biological dentist. And so he's going to be a little bit more specific on, what he does, what our role would be in getting patients to somebody like him, and, how to recognize, the toxic effects of metals in the teeth and in the mouth. So that'll be next week. Anybody else have any comments, questions? Anybody has anything they'd like to present? We actually have a pretty good lineup. We're pretty well booked through almost to the end of August, which is really good. So Joel says, thanks. Good to see you again.
Thank you. I saw that. Thank you, Joel. I miss you guys.
Yeah. And so one thing, it looks like for the second year in a row, the IT people that we paid a lot of money for seems to have lost our videos. The hard drive is missing. This is what I'm told. So I don't know. And this wasn't the same company. I don't know what the heck's going on with that. So I'm working on it. That's the best I can do. We're starting to look again for next year. I don't know what the consensus was. I know the hotel was disappointing where we were. We found a much better place in Vegas off the Strip, which is made for conferences, much more reasonable. There's no casino there. There's no smoke, none of that. And there's actually a gourmet restaurant in the hotel, and it's called the Ahern Hotel. That's go to Vegas. That would be my number one choice. We're also looking at Miami as another venue. So part of the problem is, travel is horrendously expensive, and hotel rooms are now horrendously expensive. Our census was 75 paid to show up and 50 online. And the reality was we had about 40 to 50 in-house at any one time, and we had 75 to 80 online. So that flipped, and that was back in March. So we might even just consider just doing an online thing again. This works. It's much less expensive, and we're able to operate much more economically. And I know travel is really expensive, and hotel rooms are ridiculous pretty much everywhere. So we're going to take all that into consideration. So anybody else have any comments, questions? One last thing. I'll get you the exact dates at the first weekend in August. The Nevada Osteopathic Medical Association is having their summer conference in Las Vegas. If everybody been to Las Vegas in August, it's quite unpleasant. 114 at midnight. They've been offered us 4 hours to present in a breakout room. So if anybody is interested in that, let me know. And again, we probably can do it online. You don't have to be in-house. So, so we do have that available also. And with that, I'm going to say thank you. And thank you, David, again.
You're welcome.
Everybody, good night. We'll have the video up as soon as I can get it done. Usually we get it up within 48 hours on our website. And, you know, we've been doing this now for almost 2 years, and we have quite a library now of videos. So in case you don't know, it's aosrd.org/webinars. And you can get all of the, I think I have probably about 95% of all of the lectures we've done. We're coming up on 2 years doing this. So there's quite a video library there. Some of it had, some of the transcripts are there also. So and I also put up, we did independently film Dr. McCullough at our conference at the end of March, and that is on there. And he did a conference. He's written a book, I guess. He did a conference on last Monday night with Dr. Halassa, and we were able to get that video also. So that's also up there if you're interested in that. If you hate the guy, well, it's too bad. It's there. And you know, it's either a love or a hate. So, but you know, he is interesting, and he's got a point of view. And with that, we're going to say good night. Thanks, everybody. We'll see you next week with Dr. Chandler. Again, anybody who has anybody wants to present for us, we're always eager to see new faces. Fred, thanks a lot for being here.
I had a couple of questions, but these are all doctors about the integration of the dispensaries and all those drugs out there. They're neuro, you know, with the chemical ones that are out there. So but anyway, another topic.
Okay. All right. Well, I'll talk to you, Fred. Maybe you can give us a presentation on some of the stuff you've done.
Oh yeah.
Okay.
Okay. Sounds good. Thanks.
Okay.
Thanks, Bill.
All right, everybody. Thank you all so much for being here. We'll be back again next week, and I'm going to say good night. Same time, same station. Thanks. Thanks a whole lot. Okay. Thank you all. Anything else, John? Nope. Okay. Good night.
Oh, good.